In our line of work, there are some conditions that are just notorious for flying under the radar, but they can have absolutely profound consequences for our patients. Today, we're going to zero in on one of the toughest, gastrointestinal amyloidosis. Let's really dig into why this disease gets missed so often, and more importantly, what we can do about it. Just think for a second about the patients you see. The ones with those vague, persistent GI issues that just don't fit into a neat little box. That unexplained weight loss, the diarrhea that just won't quit. These might not be separate problems. They could be the very first clues to a much bigger systemic disease hiding in plain sight. So why is this diagnosis so darn hard to pin down? Well, it's because GI amyloidosis has really earned its nickname as the Great Mimicker. And that means having a high index of suspicion is absolutely essential for every single one of us. And this right here is the heart of the problem. The way it first shows up is almost never a straight line to the diagnosis. The symptoms overlap with a huge range of other conditions, everything from IBS and IBD to simple gastroparesis. And that, of course, can lead to some really significant and sometimes dangerous delays in getting to the right answer. Now, you might be thinking, okay, but this is a rare disease, right? A real zebra. And while it is considered rare, it's not that rare. We see about 4,500 new cases of AL amyloidosis, which is the most common type, diagnosed in the US every single year. So the key point here isn't that it's rare, it's that you are absolutely going to encounter this during your career. Okay, so let's shift gears and look at the pathophysiology. How does this whole thing build from what's basically a tiny molecular problem into a full-blown clinical catastrophe? How can one misfolded protein cause such chaos in the GI tract? It all starts right here with these amyloid fibrils. So normally, proteins fold up, they do their job, and then they get recycled. But in amyloidosis, certain proteins misfold into these really rigid, insoluble structures. There are actually over 30 different proteins that can do this, but they all end up creating the same pathological gunk that just gums up the works in our organs. This visual really says it all, doesn't it? On the left, you've got a normal, happy, functional protein. It's soluble, it's ready to go to work. And on the right, you have the misfolded amyloid version. It's a tangled, insoluble mess that the body can't break down easily. So instead, it just builds up and deposits in our tissues. So these fibrils cause trouble in 4 main ways inside the GI tract. First, they can directly invade the mucosal lining, which leads to malabsorption. Second, they can deposit in the smooth muscle, which messes up motility. Third, they can damage the autonomic nerves that control the whole gut. And finally, they can infiltrate blood vessels, which makes them fragile and can cause bleeding and even ischemia. Each one of these pathways creates its own set of symptoms. All right, so keeping those 4 mechanisms in mind, let's take a little tour through the GI tract. We're going to map these processes to the actual clinical signs that we see in our patients every day. The most important thing to get is that no part of the GI tract is off limits. These deposits can show up literally anywhere, from top to bottom. And that includes solid organs, like the liver. This is exactly why the clinical picture can look so wildly different from one patient to the next. Starting at the top, when amyloid gets into the esophagus, patients often come in complaining of dysphagia, difficulty swallowing, because the motility is shot. This can be for solids, liquids, or both. And in really bad cases, you can even see food impaction. Acid reflux is another really common complaint here. Moving down to the stomach, when the muscle and nerves get infiltrated, you see classic gastroparesis. Your patients will complain of just profound nausea, vomiting, and that real hallmark symptom of early satiety, feeling totally full after just a couple of bites because their stomach just isn't emptying the way it should. Now, once we get into the intestines, the picture gets even messier. You can see malabsorption, which leads to weight loss and all sorts of nutrient deficiencies. The dysmotility can cause either really severe diarrhea or, on the other end of the spectrum, constipation that just won't budge. It can even mimic a blockage, a condition we call intestinal pseudo-obstruction. And of course, bleeding is always a risk because of that vascular fragility. And we absolutely cannot forget the liver. Liver involvement is super common in AL amyloidosis, often showing up as an enlarged liver or hepatomegaly. The classic lab finding you'll see is a strikingly elevated alkaline phosphatase, or ALP. It's often way out of proportion to the other liver enzymes, which really points you towards a cholestatic pattern of injury as those fibrils build up. Okay, so the alarm bells are ringing. You have a high clinical suspicion based on all these symptoms. So how do we get from suspicion to a firm, definitive diagnosis? Let's walk through the modern diagnostic toolkit. The first thing you're going to do is order some key blood and urine tests. A serum free light chain assay is absolutely critical if you're suspecting AL amyloidosis. You'll also want to look for nephrotic range proteinuria with a 24-hour urine collection. That's a huge red flag. Cardiac biomarkers are essential to see if the heart is involved, which is a major factor in prognosis. And of course, that high ALP we just talked about pointing towards the liver. But, and this is a really big but, it is vital to remember that while these labs are highly suggestive, they are not diagnostic. The gold standard, the only way to be 100% sure, is still a tissue biopsy. And this right here, this is the smoking gun. This is what the pathologist is looking for. The biopsy sample gets stained with Congo red dye, and when you look at it under a special polarized light microscope, those amyloid deposits light up with this pathognomic apple green birefringence. Seeing that confirms it. It's amyloid. So the whole pathway is really logical. It starts with you, with your clinical suspicion, backed up by those initial labs. That leads you to get a tissue biopsy. Often, a simple abdominal fat pad aspirate is a good place to start. If that's positive on the Congo red stain, then the final, and I mean crucial step, is amyloid typing, which is usually done with mass spectroscopy. You have to know the exact protein causing the problem, because that is what dictates the entire treatment plan. This step is absolutely non-negotiable. Now, here's a really important clinical pearl for you, knowing where to look. Yeah, a fat pad biopsy is less invasive and has a pretty good yield, around 80%. But if your patient is already getting an endoscopy for their GI symptoms, biopsies from the GI tract itself are even better. The duodenum, in particular, has a diagnostic yield that gets close to 100%. That makes it a fantastic target for nailing down the diagnosis. So once the diagnosis is confirmed and you know the type, we move on to management. And this is really a two-front war. You have to treat the underlying disease that's causing the problem, and you have to manage all the symptoms that it's already caused. These two goals are distinct, but you have to do them in parallel. So the source treatment for AL amyloidosis is chemotherapy. The goal is to target those rogue plasma cells in the bone marrow and just shut down the factory that's pumping out the misfolded proteins. At the very same time, you're doing supportive treatment, which is all about managing those awful GI symptoms to improve your patient's quality of life. And that supportive care has to be super practical and targeted to the problem. For gastroparesis, we're talking small, low-fat meals, maybe even smoothies and prokinetics. For diarrhea, it's antidiarrheals. For constipation, it's laxatives and hydration. You get the idea. The core principle is just tailoring your approach to whatever the patient in front of you is dealing with. So let's end with this thought. Gastrointestinal amyloidosis. It might be uncommon, but because its presentation is so nonspecific, it could walk into your clinic tomorrow. The biggest takeaway here is to just keep it on your differential for those really challenging patients with unexplained multi-system GI problems. Recognizing it is the first and honestly the most critical step you can take toward changing a patient's entire outcome.